people who are joining us at the webinar 196 since the Andean organization Hipólito Unanue Agreement started the web seminars in May of 2020. It's been 3 years and a half of learning. The pandemic of COVID has also taught us that the capacities built and repowered this year, 3 years should not go back. And health should continue at the forefront of the policies. The research and also epidemiological surveillance and also genomic surveillance, the development of vaccines and drugs, and the measures to promote health are always fundamental for a society of care. Reflections about these and other priorities relevant for health and the well-being might be found in the Noti Salud Andinas bulletin issued on a monthly basis, which is available at the Organismo Andino de Salud website. You are invited to leave your names, your organization, and country in the commentary chat box in Facebook Live or YouTube Live. At that same space, you can leave your questions or send them through the email, the webinar horasconu.gmail.com. And this webinar we will follow as we used to do. We will start with the institutional greetings, then we will have the presentations of our speakers to then leave a space for questions and answers. You are reminded that to have access to your assistance certificate in any of the chat box of Facebook Live or YouTube Live, you will find a fixed link where you should fill out a brief survey and leave your information in electronic email. You are asked to verify that your email address, your names and surnames are correctly written for the handing of the certificate that will be sent in the coming days to your emails. To start this important day, I will hand the mic to Dr. Maria de Carmen Davila, Executive Secretary of the Andean Health Organization, who will give her welcome and greetings. Thank you very much, Magda. Well, good afternoon, good morning, good evening. It all depends where you are now. Welcome, all of you, all the participants, especially our speakers who will join us today. Engineer Roberto Silva Perez, past district governor of Rotary International District 4340, Dr. Jose Alejandro Mojica, pediatric infectious disease specialist from Colombia, and Dr. Maria Luisa Ávila Agüero, pediatric infectious disease specialist from Costa Rica. Well, first of all, thank you very much for the time you're going to give us in this webinar number 196. Since Horasconu started in May 2020 with this cycle of webinars, which is entitled Let's End Polio, Current Situation and Challenges in Vaccination. This webinar has been co-organized with District 4445 of Rotary International through its governor, Oscar Torres Montes. We wanted to address this highly relevant topic under the framework of the celebrations held for the World Polio Day, which is commemorated on October 24 every year, in honor of the birth of the creator of the first inactivated vaccine against the polio virus, Dr. Jonas Salk. Poliomyelitis is a highly contagious disease caused by the poliovirus. Although it is very rare, the virus can attack the parts of the brain that help breathe, which can cause death. There is no cure for polio, but it can be prevented with vaccination. World Polio Day provides an opportunity to renew the commitment to global eradication and ensure that this virus does not come back to the Americas. Rotary International has as one of its main goals to end polio, and it's been working worldwide towards this goal. In 1994, the region of the Americas was the first in the world to be certified polio-free by the World Health Organization, a milestone achieved after a concerted effort by countries with the support of the Pan American Health Organization. However, vaccination rates in children with all 3 doses of polio vaccine are far below the safe level, putting the region at risk of reintroducing the disease. Although poliomyelitis was eliminated from the region of the Americas in 1994, the more correct terminology is that we have eliminated poliovirus transmission in the region. The disease persists in some countries, mainly Afghanistan and Pakistan, where there is an active transmission of wild poliovirus type 1. This is the wild type, which is the virus in its natural form. There is a high risk of reintroduction of polio. We are concerned because millions of children are not vaccinated and millions more are unvaccinated, and that opens up an opportunity for a virus. This pocket of unvaccinated children has been growing in recent years, especially during the pandemic, when polio vaccination coverage declined furthermore. During the COVID-19 pandemic, polio vaccination coverage decreased between the years 21.4% in 2020 and 78.8% in 2021. In 2022, a discrete improvement was observed, and a coverage rate of 81.8% was reached, when we should have 95% of more to avoid the outbreaks. This means that we have many children who are susceptible, who could become infected with polio. At the same time, the surveillance systems have been losing timeliness and quality, something that jeopardizes the timely detection of the cases. In Peru, the coverage achieved from January to September is 59.75% in children under 1 year of age, when what's expected for this term is 71.25%. On May 23rd of this year, an emergency declaration was issued by Supreme Decree due to the high risk of polio and measles outbreaks in the regions of the country with the lowest vaccination coverage. However, the results to date are not very encouraging. As we know, poliomyelitis causes permanent muscular paralysis. It is actually irreversible, but with a complete vaccination schedule, we might prevent it. The oral vaccine includes a very weak version of the virus, which does not actually cause the disease in people who receive it. It confers protection to the intestine, which means that if the child is exposed, the virus will not progress or multiply in the gastrointestinal system. Only one case out of 7.6 million doses administered with this type of vaccine may progress to polio. But this is highly unlikely and does not mean that this is transmissible. From a public health point of view, the oral vaccine increases herd immunity. The injectable vaccine generates a good antibody response, but does not produce gastrointestinal protection. Therefore, if there are communities with pockets of unvaccinated children and poliovirus infects a child who has been vaccinated with the injected vaccine, the child will be protected against paralysis, but the virus can still replicate in his or her gastrointestinal system and potentially spread through feces and sewage, and thereby could infect others. So, there are advantages and disadvantages of the two available polio vaccines. In 1979, Rotary International initiated a project to administer vaccines in the Philippines, reaching more than 6 million children. 6 years later, it launched an international campaign called Polio Plus, seeking to raise $120 million in the fight against the disease. In 1988, at the Rotary's initiative, together with the Global Polio Eradication Initiative of the WHO, this was launched in conjunction with UNICEF and the Centers for Disease Control and Prevention. Other organizations, such as the Bill and Melinda Gates Foundation, subsequently joined. Thanks to the work of these organizations, artists, and volunteers, polio has been eradicated in most countries, but it remains endemic in some nations, such as Pakistan, Afghanistan, and Nigeria. Campaigns to vaccinate children against polio must definitely continue. It is necessary that we all help according to our possibilities. Why? Because there are still families who do not vaccinate their children or countries that have not managed to reduce or eradicate this terrible disease. I would like to reiterate to all of you our warmest greetings and our gratitude for joining us today. Well, thank you very much. Thank you very much, dear Maria Carmen Calle. After the institutional greetings, I would like to introduce myself. I'm Magda Hinojosa, coordinator of the life course of the Andean Health Organization, Hipólito Unánime Agreement, and I will be moderating this webinar, which is entitled Let's End Polio, Current Situation and Challenges Regarding Vaccination, within the framework of the celebration of the Polio Day that we will celebrate on October 24. After this preamble, to introduce the Polio Plus program, progress and accomplishments and current challenges, we would like to welcome Engineer Roberto Manuel Silva Perez. He's Chilean. He's a commercial engineer with a mention in administration, graduated from Bernardo O'Higgins University and with a diploma at said University in Conflict Management and Crisis. He has a diploma in national security. Before, he has structured financial standards at the Universidad of Santiago de Chile. He is devoted to independent consulting in administration, finance, and internal control processes and control of management. He entered the Rotary Club of Florida in 1992. He was past president in 2001, 2002, from 2002 to 2003. In 2010, he was elected leader for the program to be developed in District 7080 of Southwestern Ontario, Canada. He's been the chair of the Rotary Foundation for 2011, 2012, 2012, 2013, and until 2014, or until 22. He's been chairing the club until 2015. He's a member of the organizing team in Polio now, governor of the District 4340 in 2019 until 2020, president of the polio subcommittee from 2021 to 2022, from 2022 to 2023, and until 2024. Director of the Rotary Governing Council in Chile until 2023, and director of the Concord Foundation from 2022 until 2024. Engineer Roberto Silva, the floor is all yours. Thank you very much, Magda. I would like to say hi to Maria del Carmen and also our two speakers who will continue after me. I'm not a health professional. I'm an engineer by profession. And I would like to start paraphrasing Stephen Hawking. When Stephen Hawking wrote The Story of Time and the Black Holes, for each formula he published, he would lose 50% of the readers. I will give you dates, hopefully. When I conclude, you will be still listening. I mean, this is my maximum aspiration here. I will speak about polio. I will speak about Rotary. I won't dwell in something that's not my area of expertise. Jose Alejandro and Maria will master these issues, but I would like to start from before the participation of Rotary. In May 27, 1955, what does Rotary have to do here? It's not Rotary. It is a key date when, after a suspension, the Salk vaccine was resumed after death of someone who actually deserves special recognition in polio, as the past president of the U.S., Franklin Delano Roosevelt, who was a survivor of polio. He got it in an office during summertime playing with his grandson. And the story says that if we had TV back then, he wouldn't have become president of the U.S. because he looked weak. And Delano Roosevelt died in May 1945. He was not there even at the end of the Second World War, but through his disease, he managed to create the March of Times. And he raised awareness in the US of the scourge of polio, since in the 50s, the US suffered the highest scourge of this disease. He asked one citizen at least to contribute 1 cent, and he collected $20 million worth at that time. With no doubt, that was actually a tremendous success. So it is fair to mention someone who made this disease more visible. Let's now move on to Rotary. And Maria del Carmen was mentioning in her introduction, she mentioned 1978, but I would like to go back to 1972. We have the service avenues. This is the way that we participate in different activities. One of these avenues has to do with what we do and how through this we can contribute to the society. In 1972 was actually relevant because the governor of Pennsylvania attends a talk in Oakland where Dr. Robert Hinson was giving some talks there. I don't know if it rings a bell. He's the inventor of the weapon of peace. And after this, there was a vaccination journey in Guatemala, something that was actually very important in Guatemala. In 1978, the effort by Jeb Davis, president of Rotary International, together with others, implemented the 3-8 program, Human, Health, and Hunger. President Davis invited Dr. Hinson to a meeting of the board. He presented his invention and he challenged the board of Rotary International to create the World Vaccination Day. Rotary got really enthusiastic with this, and we got 1979, where Dr. Sabino Santos decided to introduce these three H's to immunize children in the region of Philippines against polio. The argument were that the Philippines had 45 of the cases of the region and 74% of the deaths from polio. In 1979, James Bomar, together with the dean, Charles Gabor, and Mark Cabarras, who both Gabor and Cabarras would become presidents of Rotary International then. They visited Ferdinand Marcos, president in Philippines, to discuss this issue. And they didn't know about Ferdinand Marcos' answer. They told the Rotaries, you know what? I don't know anything about it. Talk to my wife. And coincidentally, at that time, Times Magazine or Life, I don't remember exactly which of them, had published a criticism to Imelda Marcos for her shoe collection. And she didn't want anything to be about the US. But these three men talked to her, and she heard them, and she listened, and she said, okay. She gave the green light, and they opened the wall, the door to the Palace of Government. They already had all the vaccines, and there were children waiting for the vaccines. Let's move forward to the times of Stanley McCaffrey, where there were new horizons established to promote a long-term view. And the chairman of that committee was a person who would become president of Rotary International. And he urged the Rotary to present suggestions of what to do in this New Horizons approach. And he called, and something by John Sievert, former governor of Potomac, Maryland, the proposal of immunize all the children in the planet against all immune preventable diseases at the latest by the end of the 20th century. The committee found this project very large and appealing, made some introduced some modifications, and finally the proposal was taken to the directive board and approved. And this would be the gift of the Rotaries in its 100th anniversary. Fast forward to 1985. The president of Mexico, Carlos Canseco, provided a new boost to these initiatives. Dr. Canseco was friends with a very well-known man in the world of polio, and based on the vision of Dr. Saban, who had a vaccine, there was an idea to immunize all children simultaneously, to introduce a massive campaign and a World Day, Vaccination Day, since we were saying that the greatest the number of vaccinated children, we were generated this so-called herd immunity. Thanks to Dr. Carlos Canseco and many of his friends who trusted the potential of this program, WHO accepted Rotary as an official collaborator. In February 85, the 80th anniversary of Rotary International, Dr. Canseco announced the Polio Plus program. The General Secretary attended the General Assembly of the 40th anniversary of the United Nations, and before the heads of state, he presented this idea and the commitment of Rotary with the immunization against polio by 2005. Clearly, any organization by itself could start this enterprise. So there was an alliance with the WHO, UNICEF, and furthermore, Central of Disease Control of Atlanta and the Bill and Melinda Gates that joined later and the Gavin Foundation today. In this plan of giving out a polio-free world, there were different campaigns established through an expert consultant. There was a detailed plan. There were directors allocated. The world was divided into zones. And for you to see a world committee with 11 coordinators, 44 national committees, 84 coordinators, national coordinators, and 450 committee chairpersons. In Philadelphia, the general coordinator of the Walter Madden campaign started a checklist to collect the world figure of $220 million. When 43 committees have been already given out their figures, there was $100 million achieved. But we still needed Bahamas, Bermuda, Puerto Rico, the US that aimed at 78 million. The president of the committee, Herbert Brown, who would become president of Rotary International, handed $119 million with a total collection over $290 million. Some say that maybe it was the best time of the Rotary. Starting in 1988, there were other successes of this campaign. At the beginning, someone mentioned the eradication from the Americas. There was this last victim of polio, Luis Tenorio, and I would like to mention an exceptional Rotary, Gustavo Gross, who was a leader promoting eradication of polio in Peru. But this, well, someone say that this is still written that polio is actually about to be eradicated, but I don't think so. I think that polio is still a hurdle that we need to overcome. 50 years from the first approaches have gone by. There has been some tear and wear of the members, and we need to be reactivated. We had battles in each one of the continents. There were vaccinators, physicians who died, support staff who died. It's not been easy, and it's been sad at the same time. Today, we have polio confined, so to speak, to Pakistan, Afghanistan, or the border between these two countries, more specifically, where it's been actually very difficult. This year, we've had 19 cases of polio. Some of them have been recently confirmed, but we are not giving up. We have to bear in mind that polio is still at a flight away. There has been traces found in wastewater in Brazil in the Olympic Games. We still have something in New York, some outbreaks in Israel. We really don't know what will happen with massive exodus of Palestinians from Gaza, because the control barriers will be broken. If we think that from Islamabad to Santiago, it might take us 59 hours to fly. We are not that far away. We cannot quit. We cannot give up. The strategy of the coalition is more alive than ever. There is a commitment of those who support us, like Bill and Melinda Gates. But I would like to finish with some data from the World Initiative of the Coalition for the Eradication of Polio, that is today focusing on surveillance mostly. Today, this is actually the key to get to eradicate the wild type of polio and the eradication of the vaccine-derived polio. These are the two main strategies of the coalition. In the Action Plan 2024, it is fundamental, they say, to speed up the case certification processes. From the moment a case is reported, the sample is sent to the lab, it takes a long time. We want to cut down these times to 15 days because the faster, the better. Today, we need to improve our capacity to detect the cases. It is important to improve the capacity from the labs to process the information and the accountability, the management of information also. Today, the tools out there allow us to map and to be able to detect the occurrence of cases at a speed or either the statistical information very fast. And therefore, we need to apply all of this to the campaign. As we say at Rotary, we are almost there, but maybe almost is the most important part of this statement. Polio is not at the rearview mirror. Polio is one step back. Why do I say this? Because no doubt the way forward is much more important than the one we are already living in our past. We embrace when we are coming down from so many countries to 2 countries now in the world, from so many cases to so few cases now, but we still need to turn these 2 into 0. Only then we would have achieved our mission and also our word. We were supposed to eradicate polio as a Rotary. And maybe this won't be on 2023 or 2024. We hope that WHO will revisit the criteria. As someone mentioned at a presentation, but we are going to do this. And last, I would like to salute you because the more, the better. And we will get to our goal. Thank you. Dear Roberto Silva, once again, thank you very much for your excellent presentation. You have shared with us in these 20 minutes very important information as to how this whole fight has been characterized against this scourge of humankind, which is poliomyelitis. You've shared with us interesting stories like something that you mentioned as to how everything started in May 1955, where the vaccine was resumed when former President Roosevelt died, a survivor to polio, and someone who managed to introduce the Dimes March, and he raised awareness against this scourge in the US, and a collection of 20 million to be able to fight this. You've shared with us important actions by the Rotary International, also how Carlos Canseco from Mexico, through his friendship with Dr. Sabin, organized this massive immunization campaign to be able to improve vaccination rates, oral vaccination, and herd immunity that we know is important in people who live in countries with low coverage. This is how WHO accepted Rotary as an official collaborator, and a historical date was announced through Polio Plus in 2005. We had important alliances then with many other organizations like WHO, UNICEF, and many others, and with these immunization committees worldwide. This is a very important endeavor around the world to raise actual awareness to fight this disease in a coordinated manner. You have well put it, and we need to emphasize this. Polio is still with us. We need to overcome this disease. More than 50 years have gone by since the Rotary started fighting polio, and you have said that we need to reactivate this. There's been a lot of battles in the continents. People have died, physicians have died, many collaborators have lost their lives. Now we know that this is very strong in Pakistan and Afghanistan, but Rotary is not here to quit. You have mentioned this very expressly. We are at a flight of distance. There are no borders now. There are still outbreaks in Israel with the exode that we have now to face because of the problem in Gaza. This creates a higher risk, and therefore we cannot give up. So we have to be more focused. You have given us very important information. Surveillance, of course, is of the essence to eradicate this disease. This is something that's considered to be very important. You have said that it's important to accelerate the certification of cases, and now it might take up to 35 days, and this shouldn't last more than 15, so that we can have a timely action and blockade of this disease. We need to introduce better capabilities at the labs and also have access to data. All of this has been very important. Engineer Silva, thank you very much. Thank you very much for your excellent presentation. We have already received very positive comments and questions. Please do not leave the room, because in the end, we will have a Q&A session. Thank you very much. Now, to analyze the situation of poliomyelitis in Latin America and the Caribbean, the anti-polio vaccine, and the urgent needs in terms of coverage, we would like to give the floor to Dr. Jose Alejandro Mojica, who's a physician from Cartagena University in Colombia, pediatrician of the military hospital in Colombia, infectious disease physician of Universidad Nacional de México, HIV master of Universidad Rey Juan Carlos of Madrid, medical director at Sanofi Pasteur. Now he's an infectious pediatrician at Country Clinic. He's part of the Subred Sur Hospitales, Tunal Mason. Now he's working at the Ministry of Health in Colombia in the extended immunization program and at the Deputy Direction of Transmissible Diseases. Welcome, Dr. Mojica. The floor is yours. I'm sorry, I think that he's muted. Just a second, please. I'm sorry. Good afternoon again. And thank you very much to the organizers of this event for considering me for this presentation. It is an honor for me to share the stage and this space first with the audience and then with my colleagues, Maria Luisa Avila, my dear friend, and Dr. Roberto Silva. Thank you very much for your presentation and introduction. Now it's my turn to speak about polio in Latin America and what are the measures that we are implementing in terms of coverage. And also, what about the measures towards the eradication. We will speak about some general aspects of situation in Latin America and in the world, and then I will give some recommendations. Poliomyelitis, and Maria del Carmen mentioned something about it, that it is actually an infectious disease caused by poliovirus. We know how this is a disease affecting the central nervous system, but also it causes permanent paralysis. There is a high percentage of people who, when having contact with the virus, have an asymptomatic disease, but 1 of 200 people have this sort of paralysis. This is a small RNA virus. There's 1, 2, or 3 types of polio. There's no immunity. Heterotypical immunity is minimum. It covers the type that the vaccine was developed for. Fecal oral transmission, there are 7 to 10 days before the start of symptoms, and it might be present for weeks. And immunocompromised patients, it could take a lot of time. There are 2 endemic countries, Pakistan, Afghanistan. It is interesting that polio as such, type 2 and 3 are eradicated. The wild type of polio is, there's a polio virus related to the oral vaccine. We know that there's a percentage. Once the virus is eliminated, there's a mutation percentage of 1%, but we know that it can cause some virus-derived disease. However, there's a circulating poliovirus denomination where 1% might change from the original virus. There's an isolate in the environment in a person, and in an immunocompromised person, we talk about vaccine derived viruses. What's the most important thing here? That we know that today there are some accomplishments around polio. We were able to eradicate polio in 2015, wild type 3 in 2019. Africa declared itself free from wild type polio in August 2020. So this is something that Dr. Silva mentioned. He showed these figures already, 1988, 2020, 2023, and the problem is not this. There's a commitment at a global level to eradicate polio. And this is a responsibility of different areas, not only health, but also the community, the acceptance of vaccine. Dr. Maria Luisa will discuss everything related to certify the eradication and then take all the measures necessary to never hear back about polio. But we have to bear in mind the strategies and the goals to interrupt transmission of all polioviruses in endemic countries and to stop the transmission of circulating virus and avoiding outbreaks in non-endemic countries. This has been something very important regarding the evolution, and key is the strategy to eradication. In 1988, there was a launching of the strategy for the eradication of polio. Then we have the epidemics of 2000. The last cases were registered in 2012. The recommendation of universal polio in 2014, oral trivalent polio to provide the attenuated virus, where the polio was no longer included in the trivalent. So now, I have already mentioned this, but see that in 2016 there was a change, and There were other cases in 2017, 2018, 2019, but the type 2 circulating vaccines were most shocking. There are different cases stemming for polio too, but at the global level, if you go back to this publication, there are 35 cases in 2020, 128 in 2022. The Democratic Republic of Congo was also affected, and there were 1,082 cases in 2020, 682 in 2021, and type 3 in Israel. This was published last month. Last month, there were 8 cases, now 9, of the wild type 1, 200 cases approximately, and circulating virus coming from the vaccine type 2, approximately 500 cases. Until 2023, there was a much higher number of polio caused by vaccine-derived cases than wild type polio. However, you see, and this is something that I would like to mention, because in 2020, in 2021, in November of 2021, there was a case in Malawi where there were no cases of polio. This was documented through America's CDC, polio 1, wild type, but it was genetically related to Pakistan's 2020. In 2022, last year, there was 1 case in Mozambique, then 7, and it was shown that they were genetically related to Pakistan, because those places where this new polio appeared, apparently free, this is something that is actually shocking. I'm sorry, but he's speaking way too fast. I'm trying to keep up. In Tajikistan, on January 2021, there was a CVDP-V2 case confirmed. The virus was genetically related to one isolated in Pakistan, and similar situations were registered in Ukraine with the war in September 21, and they were genetically related with the virus that was circulating in Tajikistan 2021. There were 6 contacts, and another case of polio was confirmed. When we take a look at Israel, 1 3-year-old had the virus isolated with paralysis confirmed. It was type 3 polio, and in Jerusalem last year in June, there were cases circulating in Jerusalem after the Sabin-like type 2 was isolated in environmental samples. So this is something that happens in the world, and in the Americas, we have some cases, and there was an epidemic in La Española. The strategy as such, the bivalent, and make sure that surveillance is actually applied. We need to basically bear in mind that there are circulating viruses and continue with the containment by the labs. This is what we have learned from in the 90s, where we saw how in 2014, 7.7 million doses per case, but this publication by Dr. Mario Elisa Avila in 2020, where you would expect to drop the number of cases with the number of doses applied. In Brazil, there were many cases than those expected. So this is something that we did in Colombia, in my country, where in 2015, we changed the oral dose to the inactivated. In 2020, the third one, and in the midst of the pandemic, we move on to the fourth, and now we have inactivated vaccines. We had 0.85, and during the pandemic, we had surveillance that was over 1. And this is the surveillance reported by PAHO and WHO in their publications. This is the different countries in the chart in orange to the left. This is basically the average that should be over 1. And Costa Rica is excellent. And in Colombia, it's over 1. Chile, very good surveillance as well. This is a summary of the past 5 years, but actually surveillance has been intermittent and heterogeneous. This is something that shows that in the past years, from 1994 until 2023, we were over 80% coverage. We reported the last case in 1991, similar to Peru. We were certified in 1994, and the last case was in the Colombian Caribbean, but we've had cases of circulating cases, like in 2009, one child died. They didn't realize that it was immunodeficient. This girl in Colombia was documented to be immunodeficient. She had received the third dose. She had a quadriparesia, and we needed to use capocapavir with some degree of experience. The CDC had been using this as an experimental drug. And 1 week after, she continued with the elimination of this virus. In Bucaramanga, in the northeast of the country, with all the life conditions, he received the third oral dose, and in 2019, we're in the transition to the other dose, and he still recovering from the paralysis. This is one of the unfortunate cases of our country. You see here that in the Americas, in New York, there was mentioned an immunocompetent child, not non-vaccinated, an adult who had not been vaccinated. It was a type 2 circulating type. In Loreto, Peru, where in an indigenous community, a type 1 polio derivated virus, the child started with the paralysis, and it was documented that he had not traveled, but there was no background of vaccination. Immunodeficiency was ruled out. So this is the outlook. How is surveillance in the Americas? And now we will speak about coverage. Dr. Silva made an introduction of IPV. IPV is immunogenic. OPV is humoral, but IPV is effective in controlling the disease, works very well with herd immunity. And it does not cause any of the complications related to the oral vaccine. A healthy child, I remember that I had to talk to his mom, and he was one of these doses, but eliminating the chronic disease long term is very difficult. And for the injection, you require skillful professionals to apply the injection. It's actually more costly than the oral vaccine. Now, yes, Dr. Mujica, You need to slow down. There's simultaneous interpretation into English. Let's not forget that we're having simultaneous interpretation. Yes, I'm a very fast speaker. I know. I only have 15 minutes. I will try to slow down. Now there's a new vaccine, an oral vaccine, a type 2 vaccine, which was authorized in November 2020. It's a genetically more stable vaccine. It's basically, it's been approved by the WHO in March 2021. It's been used in more than 700 million doses. The group at the WHO level, it's actually the choice to handle outbreaks with a very good efficacy and a very good safety profile compared to the oral monovalent vaccine and the oral bivalent vaccine. It's one of the vaccines that is actually very promising, and it's for outbreak intervention. These are the coverage in the Americas. In the past years, from 2020 to 2022, 90% with the first dose, in average over 90. But let's take a look at the second dose. You see that throughout the pandemic, it was 80% coverage in 2021, and there's a recovery, especially on the IPV, which is the first dose in blue, and the one in orange is the third one. I think that they are still using the oral presentation, but this is the coverage in the region. You will see that 95% is Costa Rica, Chile in the past years. In yellow, it's 90 to 94%. We were over 90 in Colombia. You see that it's lighter now, but around the region, we have coverage under 80% in the Andean countries and also the southern cone countries, with the exception of Chile. And this is the coverage of 2022. You can observe here the different colors. Polio 1 is darker, polio 3 is lighter, and the rate of desertion talks about how much the people start with the vaccination in Paraguay, Ecuador, but then there are some countries of the region with very good coverage, almost perfect in Chile or excellent in Costa Rica. You can see that's over 95%. And we see this also in Peru with very good coverage after the first dose. I think that this is actually very important to bear in mind. To the right side of the screen, you see the historical regional coverage, and you see 80, 81%. Now, something that I was telling you about in 2022, 90% first one and 83% second dose. This is the average in the region of the Americas. But something that I think it's also important and compelling is children without any dose of polio vaccine. In Paraguay, 31, Salvador, 24, Chile, less than 1% of unvaccinated children. Peru 7, Mexico 7, Costa Rica 6. This is also important, and we have to bear this in mind, because when it comes to analyzing, there's no single child that has not been vaccinated. We have to follow this up. And now in the SLEEP meeting, I think that we will discuss this. What are the recommendations and challenges? This is the RCC, which is the Regional Commission Against Polio. This is of last year. It's just met in July 27th, I guess, of this year. and they give recommendations for vaccination. They say that the IPv2 has been to be urgently introduced in the outstanding countries. The countries have to make sure timely access to vaccines with local strategies that are relevant. Regarding epidemiological surveillance, we have to strengthen active surveillance and revisit the negative report system in those places where these cases of PFA have not been reported. Improve also the opportunity and sensitivity of the surveillance system of the PFAs. And also, we have to respond to the different outbreaks. In this meeting in July, we can see in green those countries that entail a low risk, 21, medium risk in yellow, pink, high risk, 7 of these countries, and very high risk countries, 3 countries, Haiti, Peru, and Argentina. My country is in green, but the Latin America Society of Infectious Diseases has made a pronouncement saying that the likelihood of having poliomyelitis reintroduction in the Americas is real because of the low and heterogeneous coverage of vaccination and the lack of compliance of surveillance indicators. Well, first, we have to take a sample in the first 14 days, and we will be extending surveillance in adults. In Colombia, we started with a pilot project this year where it's been focused on sentinel surveillance in adults from 15 years of age. It's actually including teenagers up to 49 years of age to surveil if there's paralysis in adults. So apart from this, everything got worse during the pandemic, and regional migratory currents are also a factor to consider. There's also a recommendation of having 4 polio doses of inactivated vaccine, VPI. Children, it's 2, 4, 6, and a booster at 18 or minimum at school age. 4 doses of inactivated polio. In the past years, at a global level, the main problem of public health is the silent circulation of oral vaccine-derived polio virus. We need to recover the coverage, keep them over 95%. In a globalized world, we should have an epidemiological alert real time. We have to report those cases detected. And we have to keep the certification of poliomyelitis eradication. These are the 14 countries of the region of the Americas with exclusive use of inactivated polio. Canada from 1995, the US from 2000. They have been using this in combined vaccine plus the pentavalent or hexavalent that is also used in Mexico. Costa Rica from 2010. It's combined with penta and hexa. El Salvador IPV as of this year, combined as of 18 months. In Colombia, we use IPV alone. All the vaccines in Colombia are inactivated. I already told you how we have already started with the booster dose. Panama has been using this since 2022, 4 doses. Paraguay started with 4 doses this year combined with a hexavalent. Chile since 2019, and Brazil, it moves to inactivated polio or will as of 2024. Today, the trend is to consider certain risk factors. There's lack of PFA surveillance, inexistent environmental surveillance. It is fundamental to have environmental surveillance. We also have uncontrolled migration, which is something that affects all of this, and the continued use of OPVs. These are the organizations like the CDC, WHO, Bill and Melinda Gates, Gavi, and so on and so forth. We are close to the end. We want to be close to the end against towards the polio global eradication. We don't have these diseases which stem from the vaccines. I will no longer share my screen and I will wait. We've had a lot of experience in the region of the Americas because we're the first to eradicate polio, but the concern that we have now is the activated polio of the vaccine. The trend, as you saw in the sequence, is that polio-free is not oral, wild, or vaccine-derived. This is actually a challenge to all of us as infectious disease physicians and pediatricians. This is the message, and Maria Luisa, I think that now it's your turn. Thank you very much, Dr. Jose Alejandro Mojica, for your presentation. Excellent presentation, by the way. You have given us the situation, summary of the situation in the Americas, in the Andean countries. You've provided us with a lot of information about the polio virus infection affecting the central nervous system, causing permanent paralysis. Some cases are asymptomatic. 1 out of 200 has the disease, and it is always important to consider the transmission. People might be affected for a long time, and it might take a long time to eliminate the virus as well. Maybe, well, you have mentioned that there's still a lot of problem in getting a global commitment towards eradication. There have been many efforts to control this disease, but still we need to do much more. You have spoken about those cases that we've had in the past years in different places. And the situation is actually very concerning because we have not managed to eradicate the disease. You have spoken about the recent outbreaks in countries like in Tajikistan, Ukraine, and others, and many genetically related to the viruses circulating in Pakistan and some other countries. So it is interesting to know about this because, as someone mentioned in the previous presentation, the virus is one flight away. You've mentioned about the progress made by Colombia in managing in the past years to change its vaccination regime and little by little go from oral vaccines to the IPD, to the intramuscular disease inactivated vaccine. And so far, we have 4 minimum vaccines to achieve more safety and more children vaccinated. You mentioned those cases in New York. You also mentioned about the differences there's between the IPV and the oral vaccine. Both have certain characteristics, which are, of course, important. The IPV is effective and it provides herd immunity, which is also something to highlight. Sometimes we think that there's no effect, though the OPD provides better gut health. the OPV. Sometimes this could be a restricting factor, but we need to make progress. You have also discussed this new oral type 2 vaccine, which is actually more stable. It's licensed by the World Health Organization since March 2021, and it's advised for the outbreak control, as you have well put it. So excellent, excellent presentation. I'm sorry, there are other mics open. Please, you need to mute your mics. You've mentioned what happened during the pandemic, the low coverage, the optimal coverage attained by some countries of the Americas, and also some Andean countries. There are differences in the progress made, but something that's striking is this rate of desertion. There's a good level sometimes of the first dose, but you've mentioned about this dropout or desertion rate. We have to work around this as well. You've mentioned about the recommendations of the Regional Certification Commission, how we need to put more efforts so the intramuscular vaccine is introduced, urgently introduced elsewhere. It's an outstanding task, and we have to manage to get timely access to the vaccines with the true local strategies. Also, the strengthening of active surveillance, which is very important in these surveillance systems that we have in the countries. There's a very high risk of these surveillance systems in failing, and there could be a reintroduction of poliovirus. Finally, Dr. Mojica, we would like to thank you for your brilliant presentation. We received many comments about your presentation and also several questions. Please stay in the room, in the virtual room, because then we will open a Q&A session after all the presentations have been delivered. Well, thank you very much. Now, to analyze the vaccine hesitancy and the current situation of polio and how to mitigate its impact, we would like to welcome Dr. Maria Luisa Avila Agüero, pediatrician, infectious disease doctor from Hospital Nacional de Niños Carlos Sáenz Herrera in San Jose, Costa Rica. Dr. Avila is a surgeon, pediatrician, Minister of Health. She was the Minister of Health in Costa Rica. She has worked at important institutions and health centers like Hospital Nacional de Niños, Dr. Carlos Sáenz Herrera in Costa Rica, the Universidad de Costa Rica, and University of Texas. She's a clinical investigator and member of the research consortium of the University of Texas Southwestern Medical, professor, teacher, and coordinator of the University of Medical, Universidad de Ciencias Médicas of Costa Rica, as well as director of the postgraduate course of infectious diseases in Costa Rica and facilitator of the Pan American Health Organization in the elimination of rubella and congenital rubella. Dr. Maria Luisa Vilagüero, welcome, and the floor is all yours. Well, first of all, good evening and good afternoon to all of you. I'm grateful for this invitation to share with you in an activity that I think is very valuable and a topic that is very important to discuss. I will speak about the mistrust and hesitancy. I don't have any conflict here, and I will try to answer what's the impact that the vaccine hesitancy has in the current situation of polio and how we should go about to mitigate this. Of course, you know that the World Health Organization in 2020 declared that gaining public trust of vaccination regimes is one of the 13 challenges for the next decade. And unfortunately, now regarding the vaccines, there's people who have so many doubts, and the COVID-19 increased this hesitancy that some people had, because the acceptation or rejection of vaccines is a continuum. There's people who totally reject them. We cannot get to these people many times because their mindset is very complicated. Sometimes they do not get the gist. They do not understand why they are so against the vaccines. Might be ideological and not scientific. There's people who accept all and embrace all the vaccines. In the center, we have an important group of people who sometimes accept the vaccines and sometimes they don't. And this has a lot to do with their risk perception. So the definition of acceptance of the vaccine is something that sometimes cannot be well understood. And of course, vaccine hesitancy has to follow a cycle. And this cycle is basically given by the trust or the perception of disease that people have. Many people, and this happened to me very recently at a Congress, someone told me, but why are we still vaccinating against polio? We don't have polio in the Americas. So imagine if you are asked this at a Congress of medical experts, there's a perception that the risk is very low. And with the pandemic, everyone believed that they could understood very well everything about vaccines, and there have been mistakes. If people believe that the disease is no longer risk to them, the number of people who are willing to get vaccinated will drop. And whenever there were outbreaks of measles, for instance, the perception of risk comes back again and the coverage increases again. So the work of the health ministries and secretariats regarding vaccine acceptance is very important. Now, misinformation is also a big problem that we've been facing throughout the history of vaccines. From the times we were trying to control smallpox, there were anti-vaxxers back then, and there's also people who are going against everything, anti-everything, and the risk was much lower because the population affected was less than today's population. And of course, in many occasions, this is not so positive. And we know that fake news on vaccines reduce the efficacy of the vaccination campaigns. They are fake news based on lies, and this might look like something scientific, and this introduces doubts in the population about the efficacy or safety of verified therapies or vaccines. And then this goes viral on the media, and this will get to a lot of people without having the right context. No doubt the anti-vaxxers have contributed to hesitancy by disseminating information through different platforms. But something important is not all the people who have doubts will be anti-vaxxers. There's people who have reasonable doubt. These are doubts that we as professionals are in the power of answering. And this is also part of what we do in order to minimize the negative impact of these movements. Now, and this is actually a question that I've always asked myself, and I think that maybe you too. We as professionals are part of this problem. We are responsible for providing adequate information to people for them to be able to make the right decision. This article that was published in 2021, it carries out analysis through different surveys, and it reaches certain conclusions. Up to 40-60% of the providers show hesitancy of vaccines. There is important percentage of medical staff who are conveying these doubts. This affects the recommendations or referrals made to the patients. And of course, we need to have more knowledge and information on the specific efficacy and safety of the vaccine. So these providers go back to recommend these vaccines. The oral polio vaccine has played a very important role in controlling polio at the world level, and the intramuscular vaccine, which is much more expensive, but maybe has given a sensation of greater safety. And there's also a survey proving that general practitioners and those who work with alternative therapies are those who are more hesitant in vaccinating. These people are more reluctant to vaccinating and recommending vaccines. And something that I mentioned before, tackling doubts is important, but always within a framework of respect and scientific discussion. You know that Dr. Peter Hotez of Texas University is one of the people who has worked the most in issues regarding vaccines and development of vaccines. And now at some meetings, he had to he had to use dogs because he has received threats. And of course, with this type of people, well, you cannot have a discussion. Recently, Dr. Peter McCullough was someone who said, number one, that polio, diphtheria, were diseases that were no longer in existence, and if there were a case, it was manageable. And he was very active against COVID-19 vaccine and has been proposed some therapies to clean the body from this vaccine. What happened with him? Well, this is something that we will hear about later. In Costa Rica, a physician attributed magnetism to the vaccine against COVID. She was even suspended for a month. Why am I showing this? Because unfortunately, when one of the vaccines of our schedule is affected or challenged, others will be challenged as well. And the people are getting used to receiving the polio vaccine, and this type of expressions start to generate second thoughts, and the coverage will be reduced. Now, what about polio and its vaccine? How hesitancy might affect this? We know that mistrust is historical. You, I'm sure, remember the Qatar incident that happened in 1955, where 220,000 children receiving a vaccine against polio was contaminated with a live virus, causing 40,000 cases of polio. Evidently, this was a problem back then. And the health authorities back then followed some measures to ensure the safety of the vaccines. In 1963, the vaccination against polio was suspended in the US after having some badges causing this problem. In 1996, the anti-polio vaccine was revealed to contain SV40, a virus that causes cancer in hamsters. These elements were used by the anti-vaxxers to say, do not get vaccinated. However, you can have access to the social media and you can read about the Qatar incident and about the SV40. And this is a publication of 2002 where the called Immunization Safety Review, SV40 contamination of polio vaccine and cancer, and there was no human being affected by this. These are things that should not happen, of course. We are not here to say otherwise. And this picture where the people were on the line in the US to receive polio shots. This is the vaccine that was used back then, the intramuscular vaccine. And the US in 1976 declared wild type polio free. Costa Rica did it before. In 1973, Costa Rica was declared as a wild type poliovirus free country. Remember that we mentioned that the last case was registered in 1994 in Peru. Vaccine hesitancy has always existed, and we need to counteract this. What's the impact of mistrust? Less coverage, which is obvious. Mistrust on a vaccine makes many parents decide not to vaccinate their children. There's an increase in the risk of outbreaks. Dr. Mojica, my dear friend, explained how the Pan American Health Organization has divided the countries with possible risk of reemergence of preventable diseases, among them polio, and also there is a risk of a reintroduction of the virus. If the coverage is low, the polio virus might be introduced in these areas like Latin America, which have been declared polio free while ago. So this is a problem that cannot be overlooked. Mistrust puts in danger all of the progress achieved, and it might revert progress towards the eradication of the disease. And maybe we should move this date towards 2030. Asked about their fears regarding vaccination against polio and why didn't they want to get their children vaccinated, led to these responses. Beliefs, fear, mistrust, information, infrastructure. These are the three main responses. There's also some people who answered religious beliefs, among other responses. How aware were they about the dangers of the disease? This is also something that they mentioned. So this mistrust is part of the problem as well. This relates to the effectiveness and safety of the vaccine, and this is one of the triggers of hesitancy. I'm not going to vaccinate because I can have these risks. Mistrust in the organizations, and this has exacerbated during the pandemic and after the pandemic. They suspect from the government because they are not supporting vaccination campaigns. Maybe they know that there's something bad in the vaccines, and increase of complacency. While more polio cases are prevented, the demand of the vaccine will go down because the idea of this being a serious disease is lost, which is actually true. It is a very serious disease. Now, in this other publication, they said that in spite of the eradication efforts, Pakistan is still leading poliovirus transmission. And someone mentioned we need an adequate vaccination coverage to achieve eradication. And there are wrong ideas prevailing about the vaccine, which is making the efforts more difficult. Not only this, but also putting in danger the vaccinators. You see that this person is being protected by an armed military. My colleague mentioned this before. There are a lot of vaccinators who have been victims of fundamentalist groups who murder them because they believe that the vaccine is a weapon against people and not a measure for disease prevention. Now, in this study that I mentioned, the main finding is that there's a high awareness about polio, that there are still wrong ideas about the safety and acceptability of the vaccine leading to its rejection. I know what polio is. I'm not so sure how this happens. Maybe the vaccine is not so good. Therefore, I'm not going to get vaccinated. This study, carried out in Pakistan with a sample of 325 surveys, they find like the more important points, mistrust in the vaccine's quality. This is fundamental. 37% of the respondents mentioned it as the main cause of rejection. Fear to side effects. This was quoted by 15% of the respondents, and 13% of the respondents reported negative videos, and social media are, to them, a very important factor in their decision to reject the vaccine. So, we are facing fear, mistrust, and negative influence. Now, what do we know and why is this happening? This is a study that was conducted in different countries of the world. It was published in August of last year. It's relatively recent. Unfortunately, only the US and Brazil participated by they participated with a good number of people. They have Gen Z, the youngest to the silent generation, which is people aged 68 plus. What do they say? That 62% of the respondents believe that there's false or tricky information online every week. And this is somehow very concerning, very high percentage of people, and there's no difference between the generations. All of them are exposed, apparently, to this type of fake information. 4 out of 10 respondents are very much concerned about the effects of fake information in the education of the young people and effects in public health. So you see how by generations they have different concerns, but generally they are concerned about fake information regarding public health. 39% of the respondents in all of the countries say that they would share information, fake information, without them even wanting to, quote unquote. And this unfortunately happens among us professionals. And in this study, which is also very interesting, they have divided the population different groups. It included 94,000 people in 46 countries, a very important sample. 55% of those who use TikTok, 55% Snapchat, and 52% of Instagrammers trust more the influencers because these three platforms on social media are used by younger people. Facebook and Twitter, well, they believe more the journalists. We have to take this into consideration in order to know what's our target age group. And this is something that has led me to wonder why is it so difficult to find an answer. There have been many attempts to explain what's going on, and I think that the pandemic accelerated this knowledge. So we have this concept of heuristic, which is a process by which the brain makes rapid decisions. And this is why wise advice is to think things over. And in this case, the brain avoids a deliberate, rational process and defines an immediate response to face a specific situation. I think that you know what I'm talking about. This affected not only the vaccine against COVID-19 very recently, but other vaccines, including polio. So we have bias and heuristic, judging the risk based on examples that come to mind very fast. The heuristic of affection. There's also, well, no one cares about about numbers. This might be vague compared to other diseases, but the consequences are terrible. So people seem to have a better time if I'm telling a story about a child who acquired the polio at a hospital and who lived many years with an iron lung. Then we have confirmation bias. I'm looking information online all the time, and this allows me to interpret different statements to confirm existing beliefs and Dunning-Kruger effect, not realizing your own lack of knowledge. And this contributes to a negative opinion against vaccines. So there are different heuristics and biases which might influence the vaccination decisions of people in such a way where they are not rational. And you have to bear this in mind as part of what we should be doing to control the problem. To move on with the risk perception, this effective heuristic is that you are trusting narrative more than statistics. There are higher risks. Remember what happened in Colombia about the HPV, girls being moved in their parents' arms to health centers. And this actually had more effect than the number of women dying from cervical cancer. This is more emotional than real or than actual. And this is why we are having these presentations. And something that is also fundamental, ambiguity aversion. If we were ambiguous during the pandemic, this was one of the biggest examples. We prefer known likelihoods instead of unknown options with clearly defined risks, even if these options have less potential benefits. So we tell people about the vaccines and the side effects, and they see this more immediate than a disease that has not yet affected them. And this not only has to do with vaccines, but in general terms to all of us that we are exposed to as human beings. And this is something very interesting, and it is matches this issue of religious beliefs. This is the omission bias, where there is a trend to prefer damage by inaction instead of damage by action. So which of them is worse? So parents prefer those risks of not vaccinating their children over those risks perceived around active vaccination. So what do we need to do? It looks complicated, and it is, but this is how people feel. And what do we need to do after knowing all of this? How do we need to go about to reduce vaccine hesitancy? We need to know our audience. There's 5 aspects to take into account. They are on the screen. I vaccinate against yellow fever, otherwise I won't be able to travel to the jungle. Well, you know about trust, complacency, convenience, risk, calculation, and collective responsibility. We are forgetting about collective responsibility. I'm not getting vaccinated to protect myself. I'm also getting vaccinated to protect others. So these are psychological components that are actually very interesting. And therefore, we have a tailored campaign where we have to match the trends, attitudes, and experiences with the information. And we are trying to convey this to the people. And what about communication strategies is important to inform. It is not enough, but it is important. There might be counterproducing effects with wrong messages. Sometimes the message in favor of vaccine could be increasing hesitancy if they are not carefully designed. Focusing on heuristic, we need to capitalize heuristic instead of fighting against the thinking of people. The people need to consider this very carefully, and the key messages should tackle the main concerns. And this is something that the WHO has been mentioning during those last times. This strategy, which was part of something that I mentioned before, when people were interviewed, they said that training of the health personnel was key. We need to have trained people, people who might understand those reasonable doubts that people have. Awareness campaigns, robust social mobilization that will facilitate the acceptance of a program. And when you talk about lack of infrastructure, of course, rural clinics could be an important element to add to the equation. We need to generate trust through personal relationship. We need to focus on community influencers. In Pakistan, religious leaders have a huge influence, provide other health services. I take my children, but then I might take this opportunity to undergo a pap smear or diabetes screening, something like this. And we should increase the coverage on the media. The dramatic coverage on the media is also a message that is important to convey, highlighting stories of children who have been paralyzed by polio. This could be used as an alert, as a red flag. This is also part of something that we need to remember, pictures of children and adults who have suffered from this. And then what about the recommendations? They are speaking about famous physicians. 82% of the respondents advised to include a famous physician in the promotion of the vaccine. Also, religious leaders. More than two-thirds of respondents suggested this. It's like with the famous physicians, they must be influential people and positive influencers. Then we have sports stars or actresses and actors. Argentina has Messi, and there might be other famous sportsmen and actors in other countries. 58% of the participants advised to include famous people. This is also important. Facebook did this. Facebook limited the anti-vaccine content, but it looks like this is not enough. The authorities of health have to join the discussions online to provide precise information, but it is difficult when we are talking to people who actually don't want to have a discussion. They are attacking because of their ideological ideas, and we need to have a comprehensive approach. It's not just one isolated action, but many. These are the vaccinalypsis representatives. It's sometimes more difficult to understand fake science than real science. Our own lack of action is something that we have to tackle. We have social media, and we have to remember, now that we are celebrating the World Polio Eradication or Elimination Day, we have to remember where we started, where it all started. And unfortunately, health institutions, I know that health institutions, I was a minister of health for 5 years. I know how hard it is to get funds and many other things. But throughout the pandemic, we lived this. Health ministries failed a lot in communicating and communicating well because we are not experts on communication, but we need to nurture from people who are. And for health institutions and for public health, this is essential, and we should never forget it. This is New England article because it's actually very uh, thorough. What would I say now? You have to actively listen to what they say. You have to ask open questions and validate their concerns. If someone is talking about the polio vaccine, I cannot I cannot mention something that's going on in Pakistan. I have to be, first of all, empathetic, using simple language. I need to avoid using jargon, medical jargon, which sometimes makes it more difficult. I have to be honest and transparent. The counter effect of what happens with the hamsters, or, well, as Jose mentioned, this is something that affected not so many people. But if my child is part of these statistics, I need to be honest and transparent about the possible side effects of a vaccine. We cannot hide information. It is easier said than done, but we have to be patient and we have to be respectful. We can be impatient, but not disrespectful. We have to listen with patience, not judging people, avoid confrontation, and always be respectful as our duty mandates. No doubt, vaccine hesitancy is no longer a health issue. It's now a social issue, and it's necessary to improve the quality of social conversation. From a meeting of Florida International University in Global Health, where I gave a conference, they were asking, if you were the current Minister of Health, who would you like to resort to? And I said, a psychologist, a very good communicator, and hopefully an anthropologist to explain how to build a narrative to reach people. And it looks like this could be one of the ways to go about. I would like to thank you for paying attention. And now you need to pull this curve, this ascending curve of misinformation, and hopefully we will get to this happy day with polio would be a disease of the past. Thank you very much, and a pleasure being here. Thank you very much, Dr. Maria Luisa Vilagüero, for your brilliant and clear presentation on a topic that is always complex. You've presented about how misinformation and hesitancy against vaccines, how it looks like now we're discussing polio, but might happen with any vaccine. And we see this in many areas of the health sector where people, medical staff, think that polio is no longer a problem, so they are not promoting any positive message about the beauties of the vaccines, and there's less acceptance of the vaccine. Here, the importance that we have to promote at the ministries of health to improve vaccine acceptance. This is also including our own stuff. And sometimes because of his misinformation about the relevance of this problem or many other reasons, the anti-vaxxers will then gain some space, even more so with social media. The immediate information at the tip of their fingers, and not all of the information is truthful. Sometimes it's all fake, and it reduces all the efforts that we've been putting for vaccination. And they are almost all of them anonymous. Fake news are always anonymous. You've spoken about this cycle of anti-vaccine movements which have contributed to vaccine hesitancy from parents, especially in getting their children vaccinated, providing ill information to the population. We, as health staff, need to clear these doubts because we are part of the problem as well. We are part of the problem, no doubt of that. There's a high percentage of providers who are showing hesitancy to the vaccine in general. Our own staff is doubting the safety and efficacy of the vaccines, and this affects the recommendations that they need to provide. They are mandated to provide because of what they do. They need to provide faithful and truthful information to the people. We need to make this information better on the efficacy and safety of vaccines. And those who are hesitating the most are alternative physicians and general practitioners. So we have to be actually very strong in advocating for this. You've mentioned that the mistrust is historical. What happened in 55 affecting vaccination a great deal back then with a negative impact, increasing mistrust even more. And how this increased the risk of having more outbreaks, and therefore now we have a high degree of mistrust on the vaccines, which is affecting the risk of having the virus reintroduced. You've mentioned the interesting surveys and why moms are not vaccinating their children, and how strong is the lack of trust on the vaccines, fear, and the poor information is being conveyed. So you said that there is a lot of bias and heuristics. Everything's been very important, and how this has influenced vaccination and many more of these different types of biases and heuristics. It's important to listen to the tips that you've shared to counteract all of this. We need to know our audience. We need to know our target population, all of the weaknesses that they suffer from, improved trust, complacency, conveniency, all of the restrictions that you've mentioned. And we need to have tailored campaigns with communicational strategies, providing good quality information, enough information also, and to share messages which might not be counterproductive. Messages always favoring vaccination. And how the communication needs to be effective. We have to pay attention to everything that people need to know, but with empathy, clear messages, simple language, and always be patient. Dear Dr. Maria Luisa Vilagüero, congratulations on your presentation. Brilliant presentation. We have received interesting comments and questions that we will now introduce. Please, we will start with this part. We would like to thank the people who are online from the different ministries of health, from academia, from the different social organizations in Argentina, Belize, Chile, Colombia, Cuba, Ecuador, Spain, Guatemala, Mexico, Nicaragua, Paraguay, Peru, Dominican Republic, Uruguay, Venezuela, among others. We've received many greetings and we profoundly thank you for your participation. Well, to start this dialogue, we will start asking the questions which have been shared through the chat box. Question for Engineer Roberto Silva. What measures do you consider prioritary to be financed in the Andean countries in the current context? First of all, I would like to say hi, Carlos Manuel Arevalo, and all of those people who have joined. Maria Luisa, congratulations. Now, Jose Alejandro also. The truth is that Maria Luisa mentioned about raising awareness. I think that we need to invest on raising awareness. Rotary did it through incorporating famous people, Isabel Allende, Jackie Chan, Bill Gates, Jack Nicholson. Well, I don't remember about the name of this conservationist. We need to look for local talent. We included this in our campaigns. We did it in Argentina, in Sydney, the Roman Colosseum, different alternatives that were used to promote this. And remember that we are one flight away. This is not in the past anymore. The possibility of reintroducing polio is a reality. If we cannot control this, could be devastating. And all the way around, the savings also, it's $50 million per year in savings and treatment for not having infected children. So today, we have to work on raising awareness. As the action plan of the coalition says, we need to increase surveillance and the work at the lab. This is where science is, and generate more trust from the people. Health professionals know this better than me. But the numbers need to be there. There are two strategies here. We have to raise awareness with known faces, with impact, with story, and worldwide, having surveillance of the virus and how it behaves, especially in residual waters. Very kind response. We'll keep in touch, Engineer Silva. Question for Dr. Jose Alejandro Mojica. What are the challenges for the effective detection of poliomyelitis? What differences have to be considered in endemic and non-endemic countries?
Motivos, pues creo que por estas charlas es la concientización de la vigilancia
I
como tal.
think that we have to survey, especially we have to strengthen the surveillance on the one hand the diagnostic part, to have state-of-the-art technology to differentiate poliovirus and other types of virus with adequate samples when we are facing a flaccid paralysis. This happens throughout the whole region because we have migration, we have movement of people, and you know that this could take time, and there's a fundamental coverage that should better, and surveillance of flaccid paralysis is essential. It started in Colombia this year, and sentinel surveillance in adults. We always learned that surveillance look for polio is essential. It is important to take this into account, and this has extended to other ages. There's sentinel surveillance in adults. It is fundamental, and we try to improve surveillance, including groups. We're always avoiding the circulation of this virus, and if we can detect it in children by taking a sample, essentially in the first 14 days, and if we have conglomerate, we have to take several, and the ideal thing would be to take a sample and to have an adequate diagnosis, improve surveillance of paralysis, extending to other ages, and what WHO says and the global eradication strategy. While we keep changing this, well, I'm referring to what we did here in Colombia. Dr. Maria Luisa Avila talked about these strategies already. There are different doctors, Jose Maria del Castillo among them. And this meeting, which is of the National Committee of CNPI in 2014-2015, there was a decision made on the gradual change, following what the World Organization says. And we had 4 IPV, and the last one was difficult. But in the end, we had 4. And now the 5th. And we, in brief, I think that it is fundamental to bear in mind different aspects, to have a plan, to have follow-up, and you saw how much the pandemic affected us. It was a challenge because on the one hand, we had this problem, and as Dr. Maria Luisa said, if one vaccine is not accepted, this extends to other vaccines. And same thing happened with COVID. But here we were able to highlight all the people who were saved because of this vaccine. And now with the polio, it was actually a joint effort, a group effort. Working together with the National Institute of Health is essential. Strengthening the laboratory capacities also. All of this is combined for the benefit of making good decisions. Now we have to keep on surveilling to prove we are right. I don't know if I was not clear. Dr. Maria Luisa had an experience in 2008. 2007, 2008, there was a SLIPE. Costa Rica announced that they were no longer using oral polio. And this is something that Maria Luisa said. Imagine so many years in Colombia, it was gradual, but Uruguay did it in 2010. 2 years after Costa Rica, they had no outbreak. I would like Maria Luisa to extend this concept because it's fundamental. It was actually a very variable experience. Yes, thank you very much. Indeed, from 2006 to 2010, one of the commitments of the government with the population was to modernize the national vaccination program. Then we started working around the pentavalent vaccine and intramuscular polio vaccine. We had the last case of polio in 73. And we were looking for this because I can make sure that since it's a very small country, we didn't have children paralyzed because of polio, but we shouldn't wait for this to happen to be reactive. And as you saw in the presentation of the things that people associate is reactogenicity with vaccine safety. And this is because of whooping cough. Remember about the inflammation on the arm, children crying for hours. So people didn't want to go back to the vaccine. And we had coverage, very low coverage if we compare this with the highest quintile. This is what we did. We changed, and fortunately enough, things were going pretty well. It's over 90%. We don't have so many anti-vaxxers here. We do have people with reasonable doubt. And as I said before, one vaccine in the regime that fails or without it, this could affect the whole program. This was a very good experience. We introduced the vaccine against pneumococcus. We were one of the first countries to use a 7-valent, then we moved to 13-valent, and the results of the vaccine were actually very good. And we had this strategy, cocoon strategy. We get everything ready and we trust the scheme. And for COVID, coverage is low. There's a false perception that COVID in children does nothing. And unfortunately, this is not the case. If a rhinovirus leaves them at the ICU, imagine a SARS-CoV-2. So there's still a lot to work on in terms of hesitancy. We need to work with psychologists, anthropologists, and communicators. Well, hopefully communicators on health issues and, well, listen to the messages that we are sending out there to people so that there's no confusion. Yes, thank you very much. I would like to give an additional comment. Well, thank you very much. There was hesitancy, and there was a cohort study of 2017, 2022, looking for, well, the deficit, those who were susceptible because of not getting vaccinated, less than 80%. So in this cohort study, 7% barely of this million vaccinated were susceptible, and we identified these departments who were susceptible. And there was identification of the border, the Colombia borders 5 states, and we saw which of these borders 88 municipalities declared, and there was 25% who were not complying 80%. We saw that 6 departments did not reach 80% in the past 2 or 3 years with the pandemic. So what was the commitment? Selective vaccination. The departments were already identified, the places were identified, and what's the susceptibility degree. So I think that this will facilitate the task of completing this. We will look below the stones, below the rocks. Maria Luisa has said this. COVID with children has not been the best because we are having a lot of problem with this in pediatrics. This is not something that happened with adults. We have to vaccinate 600,000 children, and we've vaccinated 60,000 with messenger RNA vaccines. We waited to have vaccines for children, and this was actually a disaster. With all of these changes that we've had, we have to mediate. What happened with COVID is not so convenient, but we've been introducing important changes, and we have to improve the acceptance and hesitancy with communication, with everything that very nicely Maria Luisa has explained. Thank you very much, Dr. Mojica and Dr. Avila, for your insights. Question for Dr. Avila. What advancements have been studied on vaccine mistrust in endemic and non-endemic areas? What other lines of research are you considering relevant? This is actually a very good question. As I told you, I don't have those studies in mind now, but when there's an endemic area, and this happened during the first vaccines, and the lines were endless. They wanted their vaccines. So there's a high perception. The hesitancy goes down. So if well, maybe this has happened in all of your countries. When there's a case of meningitis and you know that it's meningococcus, people will rush their way to vaccinate themselves. They are not even asking what's the type of vaccine they are getting. So if this risk perception goes up, hesitancy goes down. And this is why we've always said that vaccines are victims of their own success. Very well. Thank you very much, doctor. Well, given the time, we would like to thank you for your questions. We didn't manage to answer all of them. There are many more questions that remain unanswered. We will bear them in mind to define the next webinars. We value your interest, and definitely to be able to close this cycle of questions and answers, leave a very short message to each one of our speakers. Engineer Roberto Silva, doctor, engineer. Thank you very much. I didn't mention this at the beginning. I'm conveying the greetings of 23B zone national coordinator. Because of family reasons, he couldn't attend this meeting and he asked me to replace him. So I'm conveying his greetings. And on behalf of Rotary International and McKinley, I would like to thank you for being concerned for this issue, concerned and occupied. I think that the more of the people who worry about this, we will get to our goal. We will have written one of the paragraphs of these last paragraphs that we would like to close the story of polio in the world. Thank you very much for everything that you've been doing and that I know you will keep on doing for this campaign. And I hope that we will see each other again. Thank you very much, engineer, for your contributions. Dr. Jose Alejandro Mojica, now the floor is yours.
Está apagado mi micrófono. Que este mensaje suena como de cajón. Que después del agua potable, lo que más ha impactado en salud pública son las vacunas. Eso sí es sin duda. Entonces, esto de los cambios y la innovación en los
In
programas de
change
vacunación.
and innovation, this is something that's considered to be very important. We had 4 changes in the country. These changes are dynamic, are changing, and this is actually a commitment. It's interdisciplinary, not only health, it's education, it's economy, and it's a whole group of people who favor these changes. And now regarding polio, we contribute with, well, as pediatricians, as people, because laymen, we don't want to have polio anymore, either wild type or other types of polios. So these changes that we are introducing in the region, there are 15 countries
oral y que tenemos polio inactivado en los esquemas completos. Entonces creo que es, y tenemos la visión de que el
and
polio
we have
inactivado
this
es
vision of other parts of the world where despite the inactive
y
polio
vamos
has
a
been
desarrollar
used and they've
unos
not
modelos
had
de
any outbreaks,
implementar
we
todos
are
estos
not
pilares que
giving
eran
up.
diagnóstico, cobertura
You have to work
pero
on
básicamente
surveillance,
control y
diagnosis, coverage.
conocimiento.
It's a
Entonces,
whole effort and a
esa al
quite
final
challenge.
no está
Final message is
glorificando
that
el polio, mis hermanos,
we
porque no tenemos
want to
hace más de
reach
4
that
años
point where there's not
polio
even
casi no
one
se reporta.
case
Entonces, que nos
of
enfocamos en eso y sigamos trabajando
polio.
en eso. Muchas gracias por la invitación.
Thank you very much. Dr. Maria Luisa Avila, now the floor is yours. Well, first of all, I would like to thank you. And my message is that in this globalized world with diseases come by plane, we have to be convinced and sure that no one is safe until we are all safe. What happens in Pakistan, in Afghanistan, in Chile, in the US, sooner or later will affect Costa Rica and all the way around. So if the pandemic taught us something, is the need to have one health where animal, environmental, and human health is directly related. And I would like to salute the Rotary Club. We have a very close relationship with the Rotary Club in Costa Rica, and they've carried out impressive work in terms of polio. Hopefully, this will lead to a polio-free world. Thank you very much for your final words. Once again, thank you all. Thank you for your excellent presentations, Engineer Roberto Silva, José Alejandro Mojica, and Dr. Avila Güero. Thank you very much for having accepted this with so much joy. We would like to thank all of the attendees, the Horas Konu team, and all of the people who were part of this activity that was possible thanks to the commitment to Andean integration and Latin American integration as well. I would like to hand the mic to Dr. Maria del Carmen Calle now for the closing of this webinar on behalf of the Horas Konu. Sorry, Doctor, floor is yours. Thank you very much. This webinar has been fabulous. I'm very, very happy, Maria Luisa, Jose, you know me, and I always say what I think, and I'm super happy. It's actually one of the best webinars we've had. You know that I like all the webinars. All of them will be published, and I will send this to each of the Rotaries. Couldn't be here. We have Rotaries here as well, but there have been 3 fabulous approaches. I know that this eradication is very difficult. We've seen, you know how the Rotary International has been leading this way towards the eradication of polio. This is not because I'm a Rotary, but I truly agree with it. I was chased to become a Rotary until one day, I don't remember what was happening, but at 3 a.m. I turned on the TV and Margaret Chan was there. She was the director of the World Health Organization, and she was thanking the Rotaries. So I thought this was a message from the outside. So the day after, the minister back then told me, Mari Carmen, go to this meeting and replace me. And I met Gustavo. So in less than 2 days, we've been having this situation, and then I decided to become a Rotary. My husband was a Rotary, Uso Savera. He was already a Rotary, but I said, no, I have to become a Rotary. This being the first part. And the second part, Jose Mojica, with all of his data, his analyses, and the virus, and all the viruses have to be taken into account. And this is not only about coverage, there are many other things that we need to do with intramuscular vaccines first. But so, Mari Carmen, you're always so modern, you're always so innovative, but they told me to wait, and we have waited, and we are now in Peru with 3 doses, and we are still having oral boosters. I think that Maria Luisa has nailed it. We have a very serious problem, and Latin America has always characterized by vaccinating. It's the star region. The priority here is trust. And it's not vaccine trust only, it's trust on the professionals, it's trust the ministries, trust on health services. And this has been lost. And there's something that has been important, and this is why I very much liked your surveys, Maria Luisa, because there's a part where you're presenting and the Generation Z. What happened in these 3 years? There was no children in pediatric consultation. There were no children talking to the parents, pediatricians talking to explain what's the vaccine about. Remember that these years have been lost. And if we realize of those who are part of the vaccine group, these are the younger people and not the youngest. And I very much liked this difference. So one thing is to have reasonable doubt, and another one completely different is to be an anti-vaxxer. And we need to show respect. And this is for health professionals. We have to show respect. And to show respect, we have to gain knowledge. We need to know where we are at. We need to know that the two last cases are Afghanistan's and Pakistan's, and we need to have the numbers and the coverage. And this is why I always share the coverage of the vaccines with the Rotaries. But we need to know how to support. So I'm very happy with this webinar. I think that I would like to hand the mic to the governor who has joined us of District 4455 of Torres Montes.
Muy buenas noches, amigos. Muy buenas noches a los queridos ponentes, ¿no? Les agradezco mucho por este maravilloso
Well, thank you
webinar
very much for
que
this
nos da, como
webinar
siempre,
that you have
la alianza
decided
magnífica que tenemos
to
con Orasconu
launch a
y
magnificent
felicitaciones
alliance that we have
a
with
ambos
Orasconu, and
organizadores
congratulations to
porque
the
en
Rotaries
este
for
evento muy importante para
fostering
nosotros,
this in
para
such a
nuestros
very important
estudiantes y
month.
aprendices. Agradezco a nuestros
I would like
invitados
to thank our speakers
por habernos
for
aclarado sobre todo muchas dudas que nos surgieron. Les
having
voy a pedir que me
cleared
ayuden, por favor.
certain
Este tema
doubts
nos lo
that we
quiero
had.
guardar porque es
We would
sumamente
like to have
relevante
this webinar,
y les agradezco mucho por toda esa información.
and thank you very much
Como han
for
podido ver,
this information.
este mes, les cuento que hace poco
This
estuve en la
month,
región
well, I
de
was
Moquegua,
in
al
Moquegua,
sur, obviamente, del Perú, regresaba de la ciudad de Tacna y decidí almorzar,
and I
obviamente,
decided
todos almorzar los rotarios
to
que
have
viven en
lunch
Moquegua. Y resulta que
at
después
the
de la
Rotary
comida
clubs.
le pregunté
And
a una rotaria, ¿y tú a qué te dedicas?
I
Porque
was
yo soy una
asking
enfermera y soy la coordinadora de vacunación aquí en Moquegua.
someone
Y
about
entonces, y en ese momento me ubicaron y me hubiera dado
the
la lista
Rotaries,
de todas las
and they gave
coordinaciones.
me a list
Y
of the
básicamente
coordinators.
abrí el grupo y dije,
I
dije, bueno, ¿y usted
opened the
conoce quién?
group,
Le dije, sí, me dijo, ¿quién te ha dado mi nombre? La doctora Mari Carmen Calle. Oh, me dijo la doctora Mari Carmen. Me
and
dijo, por supuesto que sí, qué gusto poder haber
she
trabajado
said
con
there was a
usted,
pleasure to
Diana.
work
Y justamente Diana
with
me
her,
hizo
and
mención de algo muy
Diana
importante, que
told
sobre
me
todo
something
ella,
interesting,
que
which
está
is
trabajando obviamente
those
en las
things
regiones tan
that
intensamente en el Perú,
happened
porque
in the
hay algunas,
regions in Peru,
algunas obviamente más
so
intensas que otras,
some even
dependiendo
more
también de las regiones,
intense than the others, depending on the
pero
size of the
hay
region.
un esfuerzo,
But
¿no?, que está haciendo el Ministerio de
these
Salud y
were
sobre todo los
efforts by the
gubernamentales que
Ministry of
justamente
Health, and
descubren pues que hay
they
muchos niños que no están
discovered that
registrados
there are many
adecuadamente como
children who have not
residentes
been
en el registro
registered
civil del
at
país
RENIEC.
y se dan con la sorpresa de tener entre 5 y 10% obviamente de niños que no los tenían empadronados. Entonces, cuán importante ya no solamente es la vacuna, sino también es registrar a los niños que no se tienen todavía.
Registering the
Me
children
gratamente
children which have
sorprendido
not
por
been
esta
vaccinated. I
información
was greatly
y
impressed by
es
this
evidente
work.
que algunas regiones obviamente más que
And this
otras.
is something that some regions are doing
Entonces,
better than others.
creo que
And
con este
Peru, I
que
think
estamos llevando los rotarios,
that with the work
ya
that
todos
we've been
estamos
doing, in our
pudiendo
case,
celebrar que estamos
it's not a matter
haciendo
of
política y
celebrating to
algunas campañas de
eradicate, but
concientización y al mismo tiempo
raising awareness and
fortaleciendo
also
y creo que
motivation.
todos los presidentes intervenidos con
And
el
this is
gobierno
something that
que
we all have
es un mes muy
agreed
pro
on.
vacuna,
This should be a
se implementa
pro-vaccine.
en todo nuestro distrito. Les agradezco
I
inmensamente
thank you
a
very
ambos
much for
organizadores,
this, Jose Alejandro
a nuestro
Mojica, María Luisa
querido
Ávila,
amigo el ex gobernador
and my dear
Roberto
friend, the
Silva,
former
que nos
governor
ayudó
Roberto
en
Silva,
este maravilloso
for
webinar,
this
obviamente la
wonderful
doctora Mari
webinar,
Carmen por
and
decidir
why,
ser
and of
la
course, Mari
coordinadora general de
Carmen
las
for
Rotaries
being the lead of
y para que
Orasconu.
hagamos todo este
And
esfuerzo para la
let's
esperanza
do
mundial,
our
¿no?,
best
que tengamos
to give
cobertura
hope to the
obviamente de
world
fructífero
and to
y
have
este mes
a
en el que hay
very
mucho
fruitful
enfoque en la
year
vacuna contra la
with
poliomielitis.
an
Muchas gracias.
approach towards vaccination
Gracias.
against
Nos
poliomyelitis.
vemos el
Thank you
próximo
very
jueves
much.
en nuestro
So we'll
siguiente
meet
webinar.
next Thursday on our next
Así es, nos
webinar.
estamos viendo el
So
próximo jueves
see you
a
next
las
Thursday
11 de la
at
mañana,
11 a.m.
que vamos a hablar de desastres, que también hay que tomarlo en cuenta. Muchísimas gracias. Buenas tardes, buenas noches.
Un abrazo y muchas gracias.
A todos, muy
Se han
buenas noches, que
conectado
estén muy bien.
más de 260